How do you go back? I don't know
So
what
this
all you can
MRI,
see.
does it really look like a 4 hours, 5 hours old injury?
This is, do you think this ACL is an acute?
After from falling from jumping from a bus.
You think this ACL is an acute ACL?
It is. Probably I've not given you all the, I mean, this is of course a T1 image, so you can't see that clearly, but it is acute. There's nothing, I think I got my colleagues here who was there with me.
Probably it was an old injury.
No.
But it presented suddenly with that
No. It's
trigger.
all acute. All acute. In fact,
The meniscus tear also looks like a little.
see, I don't know, you can see the torn ACL stumps there. That's the clots which after washing. It's been, don't worry about that. That's, I'm pretty sure. There's nothing else. He never had any problem.
Dr. Jago, in one of your ARS choices, you had aspiration plus corticosteroid.
Yeah, that's what I'm coming.
Reason for asking that. So the cytokine build up, all the
That's
papers that are coming
that's
in.
the whole reason which I'm trying, why acute. Because, now let's go to next. So, anyway, we did the standard, only in the addition thing which I did, I want to show surgical videos. We did AutoCAD for the trochlea and the, beaded from a condyle. And this is the MRs taken at 1 month. I did MR at 1 month and at 6 months. And you saw the MRs at 1 month. I got a bit scared about the bone edema I saw on the tibial side, but they all settled. He's done well as far as all this is concerned. The ligaments are okay. He's back shooting, he's back running. He's not started doing any his own stunts there. But my question is, at 6 months, he's got full range of movement. He's only got 1.5 month wasting, even after day 1. He started intense physio with full-time physiotherapists working morning and evening, even with all this. So I was using BFR to build up his muscles. The first few weeks, there was no wasting. I mean, I saw him even at 2 months, it was pretty good. And then he himself told me, what does the BFR do? It just caused my muscles to hypertrophy. It doesn't improve his power. So he was looking at his power, strength. He said it's not increasing. So BFR just gives us a visual feel of muscles bulk get increased, but it doesn't actually improve the strength. That's one thing is BFR. But I still do that sometimes when I see patients acutely, but I'm not too sure it really makes a difference. And don't we always need to do, this guy of course got some squat. The only thing I think I did wrong here, I think so far, is the trochlea crepitus part of it. He didn't have any symptoms and he's still not, he still has some discomfort when he squats, he says. Don't we always need to do all this knee one stage because we want to remove all this chemical mediators? That's probably the reason why I'm wondering, even with all our fancy surgery, we're still getting arthritis because there is data that acute, I mean, anytime ACL reconstruction, if the inflammatory markers, your interleukin-1, your IRAP decrease, your MMPs are increased, the patient, there's a data from Latterman saying about 25, 27% of the patients did badly, and all of them had, in the day 1 or the first sample taken, they all had all these chemical mediators, both the MMPs and all this. So maybe that's the reason why an aspiration in the beginning might be a different, or is it acute ACL? That's my question here. Do we need to start looking at the chemical management of these just than mechanical? Because in spite of us doing all this fancy surgery, we're still having issues. So do we need to do something more by aspirating? There are people who are putting steroids initially to reduce inflammation. I haven't done it. I just do doxycycline. I use your orthokine or one of those interleukin-1 receptor antagonists. So do we need to do that? This is the paper which talks about that close to 27% of people had this increased interleukin-1 alpha, decreased IL-1 receptor antagonists, and increased MMPs, and also NTX and CTX. So there is a lot of breakdown happening. If you remove these inflammatory markers, you definitely probably improve things. I did doxycycline because of every time I do a cartilage work, I do doxycycline. I don't do it for ACL or meniscus, but do we need to start looking at chemical management too?
So do you want to do this chemical management before ACL reconstruction or after you have done it?
So basically I want to remove all my inflammatory markers from inside the knee. So that's why I said aspirate and clean up and get in early. And we don't have drugs so far. Maybe it's going to come in soon. All what you can use is the interleukin-1 receptor antagonist injections with the use orthokine. That's what I tend to do sometimes to reduce the inflammation. But I don't have values yet. I'm just wondering this chance of arthritis, all these things, in spite of all this, do we need to think more than just thinking with the knee, just like an orthopedics and only mechanics? Do we need something more?
Yeah, but every reconstruction we do takes away a part of surrounding musculotendinous structure, and we try to recreate something close to what it was anatomically. But there will be, and there has always been a difference between whatever we have tried, single bundle, double bundle, your grafts, different types of grafts you take. So you always create some difference in a native knee and this knee. So there is a mechanical lower grade of that knee which has been operated, and arthritis is a consequence of changed kinematics which is bound to happen whatever we do to the knee. So we cannot change that.
So can't we treat that mechanical, the
We
inflammatory
can,
markers? and change-
addendum to that, we are, you are looking at this, but that mechanics is going to stay. It will
Yeah,
not
I'm not
change.
saying no. That's to be done, but we need to add something more. We got to look at this, reduce the chemical mediators too, and maybe we could reduce that increased arthritis. In spite of doing a perfect meniscal repair, cartilage work, or whatever we do, we know we're never good. But maybe we need to do these things too to reduce the chance of others. That's my question. That's why early surgery, removing, if you're not operating, aspirate and reduce the inflammatory markers in the knee. We know in osteoarthritis, the MMPA is increased, so we need to start thinking maybe chemical too, and not just as surgeons.
But taking from that cue, our tunnels also will then induce, we see some peri-tunnel inflammation, and also that's going to add, to that in any
So
way.
maybe this interleukin-1 receptor antagonist injecting the knee can block some of the
So
inflammatory stuff.
are we
inside.
going to the same argument which rheumatologists do? They start giving methotrexate, salazopyrin for osteoarthritis.
I'm talking in addition to surgery.
Yeah.
I'm not talking, don't avoid surgery, in addition to surgery.
Sir, what about your rationale for using doxycycline for 1 month? What science is that based on?
Doxycycline data has been there at least more than 10 years. It's from the Cardiac Research Society. It's been there for 10 years that it decreases MMPA production, metalloproteinases, which cause secondary chemical damage to the cartilage around it. And that's been proven clearly in animals.
Human
but-
studies in sports medicine, is there any data
There
to...
are a lot of guys, you talk to some of the cartilage guys, they're using this. It's very difficult to prove, but it's definitely shown to reduce metalloproteinase in the knee, so it's got a secondary beneficial effect. So I tell these patients, I give it only for a month, 100 milligrams BID. I'm not sure it can't do any damage. I tell them not to get in the sun anyway, because that's only other problem is you can get photosensitivity. But it's been done by a lot of people. So there's no clear publications except in animals.
So no human study, no clinical data?
No. Anybody else is doing BFR routinely? But don't you think this validity is just only hypertrophying your muscle and it's not actually increasing the strength, which is something that this guy told me straight, doc is not doing anything to my strength. Then I thought maybe that's what is happening. We've got a visual feel of increased muscle mass, but strength with gray.
So I think many a times you will find that, I wouldn't start BFR so early. That's the first thing. I would start neuromuscular electrical stimulation pretty on
Okay,
early
that.
for all of them. And when you come to a situation which is maybe 3-4 weeks down the track, or maybe slightly longer, where they have good strength but less bulk, and you're worried about their bilateral lower limb symmetry ratio, then I think BFR becomes a good adjunct because it causes hyperplasia of the or hypertrophy of the muscle fibers which are there, and they help in improving their limb length symmetry, which is
It's basically more visual than, it's very difficult to prove that actually.
it's visual. One, it overall improves. If you test them on an isokinetic machine afterwards, you'll find that when you test them on, say, isokinetic machine like Biodex or whatever, their scores definitely start matching the opposite side once you have BFR in it. Get them to carry on that BFR when they go in the gym as well, and do it against weights. That makes it even more better.
All right, thank you. So that's what, so should we aspirate day one? Do we wash out and operate, so early intervention? There are people who use steroids, I'm not too sure. But what I do is just use orthokine, this urine product, and doxycycline. I think it's less harmful, but I think there's a chance that we need to start looking, just not mechanics. We might have to start looking at some chemical thing if you want to change incidence of arthritis in ACL. Just food for thought.
Okay.
Thank you.
Thank you, Dr. Jacob. May I request Dr. Vikas Kumar to give a token of appreciation to Dr. Jacob?
Our next speaker is Dr. Milind Pimprekar. If we can have him on stage.